Well, good morning, everybody, and good evening, Professor Baker. Welcome to the second of our new format CSAR meetings, where the aim, as the regulars will know, is to bring you a distinguished speaker on a matter of topical interest and ask them to speak to us relatively briefly, 20 minutes or so, but then give you the chance to ask the questions that interest you rather than being moderated through the BBC, splendid as the BBC is, of course. If there's a matter of intense interest, I think we all know what it is, and Professor Baker, your fame goes before you because of your deep involvement in the policy in New Zealand and the apparent success of that policy. So leaving aside a couple of people who escaped from England and got to New Zealand very recently, more seriously, the approach that you guys have adopted has clearly been successful. And we are dying to hear, first of all, how you did it, please. But then I'm sure there'll be questions in due course about what the implications are for how we tackle things here in the UK. So it's very kind of you to join us. You're most welcome, and perhaps I can ask you to make your opening remarks.
Yes, I was going to say good evening, but I know it's morning for you, and it's a great pleasure to be joining you from the other side of the world. And I do feel this, that as scientists, we are united in this struggle that I think none of us expected to be in. And so we're really all, I think, learning how to manage this threat. And I'm really honoured to be with you today to talk about this. And I'm particularly interested in the discussion that we'll have at the end. I'm just going to go through a few slides very quickly, and then we can get on to the interesting discussion. I'm very much part of a team in Wellington and across New Zealand, and these are some of the other contributors listed here in our research group. And we're part of the University of Otago, which is actually in Dunedin, and it was the first medical school in New Zealand. There are actually only two, and we're a clinical school in Wellington, which is the capital, as you know. I thought I'd throw this in because this is actually the product of a competition to design a better flag for New Zealand about 5 years ago. It didn't actually go anywhere, but it produced some wonderful attempts that have been repurposed. And this was always one of the nation's favourites, but for some reason it never got adopted as a flag, but now it has been repurposed in the current struggle. So today I'm going to talk about some of the strategic choices, which I think will be very well known to you. Mitigation versus elimination was the choice we had a few months ago. The components of the elimination strategy, what effect it's had, how we go about maintaining this, and really some of the uncertainties and strengths and weaknesses going ahead. So we all know that there are multiple factors that are considered when any nation is confronted by a novel threat, as COVID-19 is or was for all of us. Thinking about the likely health impact, the impact on inequalities, its transmissibility, which really affects the controllability, and really this question of the certainty of information. At what point do you know enough to act? And all of us will have encountered questions around capacity, particularly smaller countries like New Zealand. What are a range of options, and what are the counterfactuals that we're using to justify our action? And we've got our own personal experience and bias and dogma. And then always the feasibility of the response. Can you actually, will the public sector move fast enough? Will the public accept what we're proposing? And the economics, which are very uncertain in this kind of situation. Like most countries, New Zealand rapidly did modelling, assuming some basic parameters. And of course, this can only give you scenarios. It can't predict what will happen. But we worked on the basis that this would overwhelm our intensive care capacity. It would result in a large burden of hospitalizations, which we expressed in various ways, like equivalent to 25 seasonal influenza seasons, for example. In New Zealand, there's now a growing concern for inequalities, particularly across ethnic groups. And this is work we previously published looking at influenza pandemics, which even now still are very iniquitous in their consequences for different ethnic groups in New Zealand, and the same for socioeconomic gradients. So when we were looking at this in January, February, early March, we had our pandemic influenza plan, like virtually every other country in the world, with good reason, because of course influenza pandemics have a terrible track record of causing major pandemics about 3 times a century. And the model here is mitigation. You're trying to flatten the curve. It has these familiar steps, probably very similar. Keep it out as maybe more related to island countries, but certainly stamping it out, managing it, and so on. And there's no attempt, of course, to contain pandemic influenza. But we started to think, in fact, looking particularly at the experience in China, that actually elimination might be conceivable. And here we were borrowing the framework that's been around, I think, for about 30 years, where you have the idea of eliminating a disease from a country or region, and eradication, of course, being the global absence. So here the approach is to stop the curve rather than to flatten it, if you're kind of using a cliche for communicating with the public. And really on the 23rd of March, and it was just really over that weekend, our government went from a mitigation approach to fully embracing elimination. And that was when the Prime Minister announced that we would go straight to a very intense lockdown. And elimination strategy, it's got these 3 parts. Obviously, exclusion of cases at the border. You don't have to have, I mean, it helps if you're an island, but some landlocked countries are also they're succeeding with elimination. The stamp it out phase, testing, contact tracing, isolation, quarantine, and then reducing transmission. And there's really only 2 ways you can do that: reducing transmission per contact or reducing the number of contacts. And so if we go through those components, the border management, we moved from initially restricting travel from China, and then expanded the countries that were covered. And this involved self-isolation as well for 14 days, and then moving to more supervised isolation and quarantine, and also thinking about air crews and seaports. And there was a succession of key dates here, moving right up to the most extreme situation where only New Zealand citizens returning could enter the country with very few exceptions, and then using supervised isolation and managed quarantine for 14 days. And I guess this is a scene repeated all around the world of aircraft sitting idly at airports. And the second component was the case and contact management. That's increasing testing capacity, setting up sites where these community-based assessment centres where you could test large numbers of people without them going into a controlled environment, contact tracing and isolation. We still have very limited digital assistance for this. And again, there were key dates from when testing got established and volumes increased. And like many countries, we were originally very limited in our capacity. And so this is really showing the huge increase in testing volumes to the point where we were testing a really similar number per capita to most other countries at the sort of upper range of testing levels. So the third part is reducing transmission, effectively pushing down the reproduction number. And everyone's very familiar with, I mean, it seems like the entire country in New Zealand now knows what the reproduction number is. But when it comes down to it, it's still got these components, these contributing factors. Duration, unfortunately, we can't alter at the moment. If we had good antivirals, we might be able to shorten the duration of infectivity. So you're really down to reducing transmissibility or reducing contact rates with a range of approaches. So looking at these two strategies, we had the system of alert levels, and sorry that's hard to read, but the principle is that you've got a high level here of lockdown, and then varying levels here of different degrees of reduced contact for people and restrictions. So looking at reducing transmission per contact, obviously physical distancing, and these basic instructions about stay at home if you're sick, and hand washing and cough etiquette. But we don't have a mask culture in New Zealand, and we have promoted the idea of mass masking, but it hasn't taken off in New Zealand. Instead, people talk about hand washing, which obviously is important, but given how this pathogen is transmitted, mass masking would be a far more effective approach. So the physical distancing, well, like other countries doing a lockdown approach, we had closure of schools, workplaces, public transport, and really the entire country was told to stay at home at level 4 unless they had very good reasons to leave their house for basic supplies or medical care, or if they were an essential worker. So all around, and this would have been in other countries as well, but really the images around New Zealand were remarkable for all of us. And, you know, I'm a keen cyclist, so it was fantastic being able, I didn't cycle on the motorway, but I cycled wherever I could, and it was just, at one level, it did seem quite blissful being able to cycle on these roads minus the motor cars. And obviously, the country adapted to various approaches to physical distancing, and a flyer was delivered to all households in New Zealand explaining the 4-level system, which proved to be a very useful form of risk communication using that approach. So there's far too much on the slide, but it is just illustrating the fact that a lot of measures were introduced sequentially, but then we went very rapidly into the highest level of lockdown for New Zealand, and that was sustained for over 4 weeks. And then the next level, level 3, another 2 weeks. So the entire country had more or less home quarantine for over 6 weeks, which is obviously a very extreme intervention. And when we look at the impact of elimination, this is modelling work done by my colleagues at Auckland University, and that showed that prior to the lockdown, we were on the exponential part of the curve with an effective reproduction number of almost 2, and then seeing the effective level 4 was a very extreme reduction in reproduction number and somewhat less at level 3. And other colleagues at Auckland University used phylogenetic methods to look at the intensity of the lockdown and its effect on reproduction number. And again, very similar result to what was seen with disease modelling, and also very similar to what was achieved in Australia and also Iceland. So they've been doing some international comparisons. So how do you define elimination? Our working definition with doing some modelling with my colleague Nick Wilson, you've got around about a 95% certainty of eliminating the virus after 28 days from the last case being put into isolation. You obviously need to have a high-performing surveillance system, and you need to exclude cases that are just detected on arrival at the airport and quarantined. And hence the grey area with these 2 recent arrivals who left quarantine early and were positive. So what are the options for countries? I mean, these choices will be very well known to you. The approach with influenza is a mitigation approach to flatten the curve. Most countries, many countries started on that and then moved to a suppression approach where you try and suppress case numbers and outbreaks, but you still have circulating virus. The elimination strategy, you're trying to take it a step further and eliminate chains of transmission entirely. And another version of that is, you could say, an exclusion approach, where you just stop the virus at the border. You lift the drawbridge, and this is what a number of Pacific islands have done, and I think islands in a number of places. So the benefits of these elimination and exclusion, of course, are that you can emerge into a virus-free country. I mean, that's the intent, or not have the virus at all. With suppression, you're really going to have to continue these measures until vaccine or antivirals arrive, or both. And mitigation, again, is similar, but you would obviously have more cases and more fatalities. I'm not sure Sweden is still in this group. It may have moved more into suppression. And unfortunately, many low-income countries, but not all, have really no substantive strategy. So these are just some example of numbers. Sorry, there's too many details on this slide, but just to illustrate, I mean, some of the countries in this elimination exclusion group, there are actually quite a few, and this is the kind of range of outcomes that you're looking at. Mortality per million population of under 5 in countries in these groups here, and they're obviously hugely diverse. China, mainland China, and down here, and obviously Taiwan achieving these results. Vietnam remarkably reporting no fatalities, and some Pacific islands, again, no cases. So that's the pattern in this group. In suppression, obviously, that's a wide number of countries, and I've just put a few examples in here. But again, a range of outcomes, but often higher mortality depending on when suppression was really started and how intense it's been. I'm not sure if there's really any countries that are truly taking a mitigation approach. I know some countries started on this and then moved to suppression. And unfortunately, much of the world seems to have no apparent strategy. So what are the threats going ahead for New Zealand? Well, we've got failures of border management, and we saw that yesterday in New Zealand. Hopefully, it won't result in any additional transmission within New Zealand. And some of these other contributing factors that will be relevant if we have the virus reintroduced into New Zealand. The wider health threats, the indirect effects of the response in New Zealand are obviously going to be severe. Our government is committed to mitigating some of those effects. There will be increased inequalities in New Zealand, and obviously at a global level, there are hugely disruptive effects from the pandemic and the response and the recession. So to maintain COVID-19 elimination in a country like New Zealand, obviously border management, we are promoting the establishment of a culture of face mask use in limited places like airports and public transport. We want to improve our contact tracing, and I think there's some really good digital approaches here. And we are now discussing a major review of our response and capacity to sustain this. Obviously, a lot of uncertainties about vaccines and antivirals, duration of immunity, the optimal mix of strategies for controlling outbreaks, and obviously in that same regard, inbound travel. We can think there are strengths and weaknesses in our response. I think there was effective advice from epidemiologists in the public health sector, very effective leadership and decisive action in New Zealand. This fairly new institution of chief science advisors were very helpful for as circuit breakers when the bureaucracy was basically not responding at several points. And I think the current government has achieved very high level of public trust and engagement. Weaknesses, I think we've seen really severe erosion, fragmentation of our public health infrastructure, wider uncertainties in the health sector, and I think quite a bit of dogma by scientists and in a way cultural factors in some areas of behaviour change. So overall, I think risk assessment and strategic decision making is obviously vital in a crisis. You need that good science and good leadership. This has just reminded us we need to strengthen our infrastructure. I think there's good evidence that we need to reform our global health agencies. I think the advice from the World Health Organization was really poor at certain key periods about keep your borders open and face masks should be reserved for healthcare workers. I understood the rationale, but I think it was not helpful ultimately. And my greatest hope from this event is it will be the opportunity for this huge reset and will really increase our ability to manage major global health threats. And I think listen to scientists. This is one of my colleagues wrote a piece recently, a public health triumph, nothing happened. And it's not just about the pandemic, it's about almost all public health advances. How will we know if our pandemic guidelines work? The world will think we overreacted. And so that is one of the challenges I think we've all encountered. Thank you.
Well, Professor Baker, that was absolutely smashing. Thank you very much indeed. Setting the scene so comprehensively and in such a precise way is enormously helpful to those of us who've been listening to various kinds of input over the recent weeks. Well, we're now opening up, and can I remind people that if they would like to ask a question, they can do so through the Q&A, or they can raise a hand and we'll spot your hand, and Edward, who's behind the scenes running the cameras, will bring you in. Please don't use the chat, and I hope you will have seen that on the rolling screens before we started. So I don't know how often you've been asked this question, Professor Baker, but it does seem to have worked terribly well. There must have been some scary moments, though, whether it wasn't quite clear whether your approach was going to work or not.
No, I would describe that as the most intense period of my working life because, you know, as a scientist, you want to be very certain if you're going to suggest something that is going to be as harmful as an intense lockdown. And I had colleagues, one in particular, who was writing pieces saying, using a sledgehammer to kill an ant. And I think he actually used flea was his arthropod of choice. But and there was a very strong counter argument at the time. And, you know, I found it personally very challenging to make this case. And I think my other colleagues did as well.
Well, I think you've certainly been vindicated. We've got some questions coming in, Professor Baker. The first one is from Tessa, and she asks, how long can you keep the virus out? Clearly, there are going to be one or two that sneak through, but surely the country can't be kept isolated until a vaccine or cure is found.
Yeah, I agree. That is a big question. But of course, as I showed on one of the earlier slides, there's a large set of countries now in the Eastern Hemisphere who are pursuing the same approach. And I think the first thing you say, you will have setbacks. And all of the countries, I think, on that list have had setbacks of various sorts, outbreaks. But overall, most people in those countries are now protected from infection. And I think with time, we're going to get better at managing our borders. And already there's a huge discussion about opening up quarantine-free travel with Australia, who are not quite at the same stage of elimination as New Zealand, but are very close. And some states in Australia have eliminated the virus. Taiwan has eliminated it. And a number of Pacific Islands have just not had the virus. So I think there'll be a growing network of countries in our region that we'll be able to move freely between.
Great, thank you. I see Penelope Coggill would like to ask a question, please.
Thank you. It was very impressive that you were able to start testing for the presence of the virus as early as the beginning of February. And I would just really like to ask where you were able to access these test units, and whether they, and what, how long it took for the results to come, and whether you then were able centrally to coordinate all those results. That's really very impressive compared with other places. Thank you.
Yes, well, my colleagues at the National Reference Centre got very organised and got test kits in quickly, and also at Auckland Hospital. I'm actually not sure exactly where they got those test kits from initially. But yeah, there was quite a long period, probably about a month, when the supply of reagents was very tenuous, and we were just going from day to day, really, in terms of increasing testing volumes. But yeah, the coordination of test results was a challenge because the information systems just weren't compatible. So they really had a daily count, but not much more than that.
Thank you.
Thanks. There's a question here from Chris Fisher, who says, taking into account the possible natural further waves of infection, the effect of easing lockdowns and the possibility of infections being reintroduced, what are the current predictions of how things will progress from now? There's a $64,000 question for you.
Well, I think we had our big scare yesterday in terms of 2 cases you've heard about, and arguably they are still border related. If there are secondary cases, clearly we have got local transmission again, and that will be a major concern. But I think the number of people coming into New Zealand every day, we actually had some days when no one arrived in the country or left. And no one could remember when that last occurred. They were looking through old records. It was decades ago. But typically now there are around about 300 people a day coming into New Zealand and going through 14 days quarantine. So that is challenging to maintain. I think there are good protocols, but making sure they're applied consistently will stay a challenge. And a couple of teenagers escaped from quarantine, and it took them a few days to find them. I mean, they weren't infected, and they was towards the end of the period, but you know, it is, you know, once you've got thousands of people sitting in quarantine facilities, things, you know, mistakes will happen.
Thank you. I see Steve Temple is ready to ask a question. Please, Steve.
Hi. Thanks for the talk. Really, really interesting. I'm fascinated by the mechanisms of transfer, because it seems to me that there's probably a higher risk of transfer by picking up of surfaces than there is of airborne infection. For example, if I go and buy some petrol, possibly 100 people will have handled the equipment in the time that the virus can live on such surfaces, and therefore I'm in contact with 100 people instead of maybe just one coughing at me in the supermarket queue. And yet this is an aspect that nobody seems to have attempted to control. Can you comment on that?
Yes, well, during the lockdown in New Zealand, a huge amount of effort was put into the concern about, you know, fomite transmission. And there was an image of people sitting in their homes sort of rinsing their fruit and vegetables with mild bleach and all sorts of other things. And yet I think as time has gone on, I think my impression is that airborne droplets, not airborne, but actual droplet spread has really risen in terms of the probability attached to that mode of transmission. And I think it's probably just about levels of infectious dose. Obviously, the testing is so sensitive, you can pick up traces of the virus on all sorts of surfaces for quite long periods, but I think the dose is very, very small. So that's my impression, is that most of the transmission seems to happen indoors, often from people who are pre-symptomatic or maybe the early stages of illness. And it's from just normal conversation, you know, breathing, talking, laughing, and singing seems to be one of the worst. But that's how all of our outbreaks started in New Zealand, and it was mainly outbreaks that we were seeing that was driving the early stages of our pandemic. And most of them were traced back to these indoor events where there was often people knew each other. They were, you'd say they were convivial. There was often alcohol, and people were getting quite close to each other.
Right, because I've been using the household bleach, and we disinfect all the shopping that comes in, and the post gets quarantined for 3 days, etc., etc. But we've had really none of that sort of conviviality at all. So haven't got drunk once.
Your bread and potatoes must taste terrible, Steve.
Well, now we've got various techniques for this, because we transfer those out of the packs into a clean pack. So I wear barrier clothing, and I cut the pack open, and Pippa holds a polythene bag from the house, and I tip the potatoes into it. So we don't actually rinse the physical vegetables, nor do we buy them open on the shelves.
Well, that's really, it's clearly working. It's clearly working for you. Well done.
Well, we haven't either of us picked it up so far, but then we live in a fairly low risk area. So
great, thank you. I've got a quick question here from Andrew Shepherd, and Andrew, I'm not sure whether he's speaking as an actor or a potential audience, but he'd like to know when we can expect theatres to open again. Or are they going to have to remain closed until a vaccine is widely available?
Is that in New Zealand or other places?
Oh, in the UK, I think the question was intended, but we'd be interested to know what you're going to do about it too.
Well, once we moved to level 1, basically everything opened Monday last week, as of midnight, so Tuesday, so really just a little over a week. And then in the weekend, we had these huge sporting events, which I must admit make me feel a bit squeamish, but because of the transmission risk. But essentially, there should be no virus circulating in New Zealand. And basically, there was huge amounts of testing being done for a month, and not a trace of virus found in a whole lot of people who are quite highly exposed, service workers, healthcare workers, and border staff. So the country, our politicians felt very comfortable opening everything up. So we'll find out in the next few weeks as to whether there was any undetected transmission, but we're not expecting to see any. So that's the benefit. I would say the big benefit of elimination, if you can achieve it, is you can come through the other side and go back to almost business as usual, at least in terms of the internal environment in your country.
That's most encouraging. I can see Mr. Knight on the phone, on the screen, I should say. Mr. Knight, would you like to ask a question?
Hi, my name's Sarah.
Sorry.
I identified myself just as S, so don't worry. I'd just like to say kia ora, first of all, to
Kia ora.
Michael. Thank you. And how proud I am of New Zealand for being able to take the risk to avoid looking foolish globally. I think of New Zealanders as great risk takers, and in this instance, the risk has paid off and will pay off for years in the future in droves for New Zealand. And my main question really is about the travel bubble. And given your expertise, when is it safe to open up the border to virus safe but not virus free countries like Australia? And when do you think that will happen? Thank you.
Yeah, no, that's a great question. There's two aspects of opening up. One is just allowing more people to come through quarantine and changing the rules, because at the moment the capacity is very small, so it's really quite saturated with just returning travellers plus essential workers and some compassionate travel. We just published a modelling study where we showed that there's alternatives that do the equivalent of 14 days quarantine using a whole mixture of other barriers, and that's for travel from Australia to New Zealand, where the risk in the travellers themselves is very low to begin with. And if you add in testing plus mask using for 14 days, it's very close to being the same as quarantine. And actually, even if you take the testing out and you just wear masks, it's actually almost as good as 14 days quarantine. Provided you trust people to wear masks, of course.
I can see that might be difficult to implement that in New Zealand.
Yeah.
So do you think that might happen in the next few months, or is there a plan for that travel bubble, do you think? Sorry, I ask is we're a New Zealand family living in Cambridge, and we've lived globally, so this is an important thing. I think there must be so many New Zealanders looking at coming back to New Zealand, and that could be a great boon for New Zealand, really. People bringing back expertise and financial, resources as well to New Zealand. Yeah, so interested to know.
Yeah, no, absolutely. And remembering, if you're a New Zealand citizen, you have an absolute right to return to New Zealand. There's no restriction. So that's it's more if you are making the case for being a migrant of some sort.
Yes.
But there are people coming in who have essential skills. So it's just a capacity thing, and I think the capacity will increase.
Thank you.
Thank you. I think you may have a lot of applications for people who are not originally from New Zealand to go and live there in the current circumstances. Thank you for that. I've got two questions now on the same topic from Bill Wicksteed and Andy Bush. It's about this managed quarantine. What's exactly involved with managed quarantine, and how is it enforced?
Well, there's two levels at the moment. If you are symptomatic or positive for the virus, you're put into a very highly controlled facility at the airport. Otherwise, you're transported to a hotel somewhere in the city, and you're supervised, but it's not at the same level of intensity for 2 weeks. And just 2 weeks ago, we added the requirement for testing at day 3 and day 12 for the virus. Otherwise, I mean, that's very restrictive, obviously.
Okay, thank you. Chris Davis, please, on camera.
Thank you, Professor Baker. Very interesting. Going back to the beginning of your talk, it seemed to me that the measures and the planning, in fact, that New Zealand went through was rather similar to the UK, the same mitigation measures, etc. But for some reason, your elimination strategy really worked, whereas obviously didn't. And I wondered what it was. Was there any key factor that made you decide so quickly to go for the elimination route?
Well, for me, it was just looking at the success of China. Basically, they stopped this pandemic in full flight in Wuhan, which many people thought was impossible to do. And it seemed to me that if it could be done there, it could be done in New Zealand as well. And the thing was just to turn the normal approach on its head. So instead of ramping up the controls as the pandemic got worse, which is what our pandemic plan said, to flatten the curve, this is the opposite, just obviously interrupt transmission. And at the time, we gave 3 reasons for doing this. One was putting everyone into quarantine is the same as contact tracing the whole country, essentially, because the cure is the same. You just stay at home. So for quite a long period. So it start all these chains of transmission basically extinguish, or most of them. And also it gave us time to build up testing and contact tracing. And also the third thing, it basically no one in New Zealand had experienced the pandemic before. So at the end of this, they understood a lot more about physical distancing and all the other things you need to do. So it was quite educational.
Yes. Yeah. Was that led by this decision? Was it led by the scientists, or were the politicians keen on being quick into lockdown?
Well, basically they went from not being at all certain, I think, very dubious. And I think it was partly the images beaming in from Italy of what happens when you get a huge amount of pandemic spread. And at that point, I think they changed very swiftly into this different direction. And they were getting obviously lots of advice from different people. But there was a small group of us who were advocating this approach. But interestingly, our business leaders also got behind this. And I think it was a Lifeboat New Zealand model. They were saying, basically, they were connected with the rest of the world. They could see what was happening in other countries where they had enterprises. And they also started to say to the government the same thing. And actually, officials tended to be really, I think, just overwhelmed. And they didn't, it was quite interesting at these critical moments, the normal ways of making decisions and communication start to dissolve. And I think ultimately at this point, it was basically the media and phone conversations and other things in terms of how all of this was happening in the space of really a few hours. We went from one approach to another.
All right. Well, I think congratulations is what we have to say.
Yeah, absolutely.
Fascinating.
Thank you. I see a question now from Michael Bright. Hi, Michael. You may know, Professor Baker, that there was a lot of concern in this country about care homes. And Michael Bright asks, how did you manage control in your care homes?
Well, I don't think we managed it very well. I mean, that's where our fatalities all occurred, or almost all of them. And I know that's been a big problem everywhere, trying to keep the virus out of that environment. And once it's there, one of our outbreaks, I mean, I know the numbers are much smaller than elsewhere, but, in a single facility, I think counted for 10 of our fatalities. And unfortunately, that's a scenario that's played out all over the world. But I was very interested in the experience of Hong Kong, I think, where they were able to fully exclude this virus from that environment. And I think it's just that real test of infection control, isn't it? So we did learn that the hard way, I think, like lots of places.
Great. Michael, I don't know if you wanted to ask a supplementary. No, we thought we had him on screen for a moment. Sorry. Michael, I think you're muted. Would you like to ask a supplementary?
Is that correct now? Can you hear me?
Yep, lovely.
Good. Thank you very much indeed, Professor Baker. Most inspiring talk. And I think it's a really marvellous illustration of decisive leadership, if I may say so, in your country. My vested interest in care homes was that for some time, I and colleagues felt that they were a hostage to fortune, particularly in asymptomatic cases. And we felt that care home residents and staff should all be tested. I don't know whether you had any further comment to make on that, and whether you thought of that in the early days when there were asymptomatic spreaders. Thank you.
Yes, it's a great question, and we were quite slow to pick up on that. It was also just a shortage of testing capacity, and then later on, we got to a stage where everyone in these environments was being tested regularly. So, but it was only when the capacity was there, and also I think as the numbers were dropping off, and there was that concern that the virus might still be lurking in some asymptomatic settings. I don't know what your experience was, but I think the virus was almost given magical properties or magical powers by members of the public, and even some of my colleagues who thought there's so much asymptomatic infection that it will be very hard to manage. And it turned out not to be as difficult as I think we thought to contain it. But I think there was a period, I don't know if that was your experience as well, but it was just seen as almost impossible, an almost impossible task for one.
Yes, I think that was the case. And I think, unfortunately, the main emphasis of the government was to clear space in the NHS hospitals to avoid them being overwhelmed. And cases escaped from the hospital into care homes who weren't properly tested. I think that was very unfortunate, to put it mildly.
Okay, thank you, Michael. I have a question from Anna Pereira. Am I pronouncing that correctly? Do do you think this kind of approach can work in large countries with a big population? Well, I think you've hinted at the answer, but please, what do you reckon?
Yeah, I'm very interested in your views on this. And of course, it's impossible to tell any other country what you think they should do. I'm still very impressed by the range of countries that have applied an elimination approach very successfully. You've got mainland China, you've got Vietnam, Mongolia. These are not countries you'd think would be easy to manage. They're emerging economies in some cases, and they have achieved remarkable results. So I do have a question for the UK, because you seem to be doing all the right things, but there is a question about the timing of them and the intensity of them. And I think even your strategic goal, because you've got quarantine at your borders, or you're bringing it in, you've got testing and contact tracing, you've got experience with lockdowns, and also with potentially mass masking, which my understanding is it can be almost as effective as a lockdown. So I would have thought you had all the tools necessary. And I know I've talked with colleagues in Scotland and Ireland who also think they would be very good candidates for elimination. But I'm just curious to know what you think about this, because if you do this, you basically just do it once. You come out cautiously from an intense lockdown, and then you don't have the virus. That seems a lot more appealing to me than this kind of purgatory where you're going in and out of lockdown until something comes along like a vaccine. But anyway, you know your circumstances much better than I do.
Well, thank you. I'm not sure whether we've got anybody around who's taking those decisions in the UK at the moment, but if they have, they might like to make themselves known, and we can get an answer to your question, Professor Baker. I see Rod Kirby is on screen. Rod, would you like to ask your question?
Hello, yes, thank you very much. That was super. First of all, could we please borrow your Prime Minister? But more importantly, I noticed you said you had a slide that said accessible decision makers. That I'd be interested to know what you meant particularly by that. But I had a situation where there was a BBC news item that I saw on January the 26th that said that in China they had found that 4/5 of the transmission was from people with no symptoms. And I immediately thought, that means we'd better test people smartly while there's low numbers to test. But there was no obvious way of getting that information to the government. And I thought, I wonder if SAGE knows this. I'm sure SAGE must know this. And subsequently, I thought, I don't think they did. So a route to decision makers would, I think, be useful. And just very quickly, I remember my dad saying that in World War II, they invited suggestions from the public, and it went through some system of checking whether they were rubbish or whatever. But that kind of thing seems to me to be worthwhile, because there are lots of people around that have got very good ideas, but you need an accessibility route to get those. So I wondered what yours was. So thank you very much.
Yeah. There certainly are benefits of being in a small society, which is a bit of a village. And I've lived and worked in Wellington for 30 years. And of course, now I know politicians, and I know my senior colleagues in the agencies. And we had this new institution. I don't know if you have the equivalent of chief science advisors in your government departments, in the Prime Minister's department. And these are people who, after a while, you can ring them up and email them and so on. And that has been, I think, a really great institution. We also have a science media centre, which is very good at getting scientists engaging with decision makers. So those institutions really, I think, worked exceptionally well in New Zealand. I think you have similar institutions, I think they're across many countries.
Mm-hmm. Yep, I think that's right.
Thank you. Well, very good.
Thank you, Rod.
Point. Okay, thank you.
Thank you. And can I go, please, to a written question from Veronica. Veronica says there's a report recently about the 2-meter social distancing. Authors reanalyzed the original data and found that the point was no touch rather than the strict 2-meter distancing rule. What do you reckon?
Yeah, I think it's very hard to. I know that the Lancet study, I thought it was very useful, that the WHO, I think, might have commissioned, but that also had a lot of evidence about the use of masks, and I do think I was originally not sure about masks, but looking at the literature, the modelling evidence, the laboratory studies seemed very compelling to me about the benefits of masks really reducing the need for physical distancing. And also, I think the fact that almost all transmission occurs indoors, I think, is another factor that's quite useful.
Thank you very much. I think on screen we have Anne MacLeod, please. And you need to unmute, please.
Hopefully I have done now.
Yep, that's fine.
Thank you. Yes, thank you. It's fascinating to hear your talk. I want to say something, maybe in the UK it might seem a bit controversial, but I wonder if you would agree whether it would be a good idea for the standard state coronavirus testing facilities to be available to someone about to enter a care home. In other words, in order to do it through the normal method, rather than having to take somebody into a care home in order to get a test. It seems bizarre. Obviously, to me, it's critical that we should avoid the virus getting into a care home under any circumstances. And I've very recently been in the situation of trying to organise a test for somebody about to get into a care home. And I'm astonished to hear that he doesn't qualify because he's not showing any symptoms.
Yes, I mean, we went through the same process when testing was in short supply, but now testing capacity is very high, and I think there's a huge emphasis on testing in all situations where there may be some risk. And I think that would be the pattern in New Zealand in the later stages of the pandemic.
Thank you.
Okay, thank you. And I've got a written question now from Mark O'Sullivan. One of the big issues with this virus is that it's been known from the start that there was a pre-symptomatic period, and you touched on this earlier, Professor Baker, obvious difficulties for managing the epidemic, and especially for tracking and isolating. We still don't seem to know how long that period is. And I guess at the beginning, you didn't either. How did you deal with that?
Yeah, look, I think that's a huge challenge. And that's where I think, masking is actually useful, because otherwise you really, if you think the two tools you've got for reducing transmission, physical distancing, is a very blunt instrument that telling people to stay at home. And the other measures of reducing the chance of transmission, unless you are wearing face masks, you've got very few options. You say, well, stay 2 meters apart. When we were coming out of lockdown and at levels 3 and particularly level 2, we were trying to maintain a 2 meter distance. But that means our buses could only run at 30% occupancy. And that was a disaster for, meant that some were not economic, and these low-income people depend on the bus service. So, whereas my assessment would be if people were wearing masks, face masks, they wouldn't need to be concerned about the physical distancing. There aren't the clinical trials to show that, the public health trials to show that, but I think the other evidence I thought was very compelling. So I would say that was the most important measure that we should have had, but we got through it without that. But I do think in the situation that the UK is in and many other countries where you've got circulating virus, I would have thought that would be a key strategy.
I can see Dennis Mollison on screen. If you'd like to ask your question, Mr. Mollison.
Yes, thanks very much. I think in one of your slides, you showed the effects on the reproductive number of lockdown. And I think in the countries that are successful countries, they've got that reproductive number down to about 0.3, which seems impressive, because I think in the UK, it's typically been more like 0.7. Now, the difference there actually, the epidemic will be declining about 3 times as fast in your case as in ours. And if the higher value here is because people are being more restless under lockdown and not following the guidelines properly, then of course, if they have to be in it for 3 times as long, you get a vicious cycle in which they're even less likely to adhere to it. So do you think that there's a difference is there, our social geography or our culture?
Yeah, no, it's a very good point. And I think in a small, quite cohesive society like New Zealand, I think it is a natural advantage. But Australia, which is not quite as cohesive, probably also achieved a similar result. I don't know. I think there are many factors. I'm sure it's much tougher in large, very cosmopolitan cities like London. But I'm sure it can be achieved, but it will be a challenge.
Thank you. And I can see a written question from Colin Fox, who asked, with the large variation in deaths per population between countries, could there be a general health level of different populations which underpins these differences?
What was the last point? Sorry.
It's the general level of health of the population. Could that be an influencing factor?
Well, certainly in terms of disease outcome, it's hugely important. And in some ways, high-income Western countries, in a sense, have an increased level of vulnerability because they have obviously been successful in creating a population of older people with multimorbidities and helping them survive and live with those health problems for longer. And so we do have just a hugely, greatly elevated number of vulnerable people. So yes, I think it is a source of vulnerability. And it's why I'm very wary about international comparisons, using something as crude as a mortality rate. So I don't think the minor variations mean that much because it will reflect very much on multiple factors. But I think the broad categories are really similar. And I do think the outcomes from this pandemic are mainly determined by governments and how they behave, with some overlay of demographics and illness patterns. But I think fundamentally it's whether governments have succeeded or failed in many instances.
Yes, and the numbers are pretty stark, aren't they? I have a question from Rebecca Clark, which I suspect will be of interest to many. Could you advise what the transmission rate is on planes? In other words, is it safe to fly?
Yeah, well, this has been a very interesting question. And so far, there are surprisingly few documented examples of transmission on aircraft that I'm aware of. I mean, it seems logical it should happen. And the experience from influenza, and I've investigated transmission on aircraft, and it definitely occurs. And there's a lot of examples for influenza. There have been some definite examples with COVID-19, but fewer than you might expect. So I'm really not sure what the level of risk is overall. I mean, it's certainly present. But again, this seems to be an environment where face masks should be routine, I think. And I know IATA recommends them, pilots' unions recommend them, and most airlines, I think, are offering them, but maybe not always requiring them.
Okay, so stack up with masks, Rebecca Clark. I'm afraid this is going to have to be the last question now, and I can see John Cook on screen, please.
Hello, thank you for your very interesting talk. I have what might be a rather controversial question. All of the strategies have been aimed at a single objective of reducing the number of deaths from the virus. But we know that many of these strategies have huge knock-on effects for the future of the country in terms of economics, unemployment, general misery, and everything that leads to. Is there anyone who has been modelling what we should do, taking those into account, other than through political bluster, but with some actual figures for the impact of unemployment on future death rate, for example?
Yeah, I think that's a really good question. And some of my colleagues have done that modelling, economic modelling, and looked at the net economic consequences of taking different scenarios. And firstly, the cost per life year saved is very high for this intervention in New Zealand. The cost per QALY is above the threshold we'd normally use for public health interventions and certainly pharmaceuticals. So it's very expensive because it's billions of dollars, of course. The question is, what are your counterfactuals? And at the moment, looking around the globe, for a while, some of my contrarian colleagues, I call them, were saying, look at Sweden. Now, then they were saying, look at Australia. And now they're kind of running out of places to look at to say they've done really well. I would say the country that's done best is Taiwan. And it's a model of really proactive decision-making. And they didn't need a lockdown. They've done it very well. But very few other countries were as proactive. But yeah, no, I think, John, it's a great question. I think, as people say, the final calculus, if that's the right term, will take probably years to fully emerge because there's so many direct and indirect effects from all of the choices we're making. At the moment, people in New Zealand are feeling reasonably happy, or actually I would say overall almost a bit smug too smug, I think actually, that we've made the right choice. I think we need to still be very cautious about it. And I think, time will tell if we got it right or not.
Well, Professor Baker, we better draw to a close. Our time is up, but can I thank you for an absolutely exemplary hour of well-informed painting the picture and then asking the questions with such authority. It's been an absolute delight. I look forward to the time when you can come and see us in person.
Yes.
Can I also thank our viewers? We've had about 100 people on, even at 10 o'clock in the morning. So it's been an absolutely great occasion for us. Do keep safe and well, Professor Baker, and I'm sure you have a better chance of doing that there than we have here. But thank you again very much indeed.